Good morning everyone. I am Dr. Monica Shah and I'll be presenting about the basics of phacodynamics. So what does phacoemulsification consist of? It consists of the ultrasound energy which gives the power and the fluidic system for the process to occur smoothly. Now what do we look for in phaco? We look for the sculpting of the nucleus, the impaling or holding power of the phaco probe, the followability of the nuclear fragments which are created, and the chamber stability at the same time. We have a foot pedal with which we operate the machine and the probe. So the position 0 is the rest position. Then we have 3 steps. First is when the irrigation starts, second is the aspiration, the vacuum and the flow rate depends upon it, and third is the power. In higher end machines there is also a sidekick button which leads to reflux. So the aspiration flow rate is inverted, and if by mistake we aspirate any tissue like iris or PC, it is expelled. We have a phaco probe which has a transducer, converts electrical energy to mechanical energy, and it has a titanium tip, and which is silicon sleeve covers the titanium tip. It has 1 mm needle at the tip, oscillates at 40 kilohertz. It has a USG transducer, and lead zirconate crystals are present, which deformation of the crystal leads to the generation of energy. Now the phaco tip, there are various angulations from 0 to 45 degree. 0 has the maximum holding power and 45 has the maximum cutting power. Routinely we use 30 degree with a good holding power, because for cutting we already have the power of the machine. There is a Kalman tip present which has the angulation downwards, especially for trenching. Now how is the phaco power generated, and on what factors the power depends on? First is the stroke length, that is the maximum forward and backward movement of the probe. Usually it is between 70 to 120 micron. The frequency with which there is the movement per unit time, and so power is frequency into stroke length, and also the one which has higher acceleration generates more power. Now various mechanism with which the phacoemulsification occurs. First is the pneumatic drill effect, that is the mechanical impact between the tip and the lens material at end of each oscillation. Cavitation and implosion. It is because of the vacuum created when the tip withdraws, but the liquid and the particles cannot be returned, and this cavitation bubbles leads to implosion. Third is the acoustic wave around the tip and impact of the particles due to the forward movement of tip by each oscillation. So this is, first one is the tip at rest, second is when it shrinks there is cavitation, and if it is expands it leads to the pneumatic drill effect. There are various modes of phaco power. One is continuous, which we use in trenching. Burst mode rarely used now, but can be used for very hard cataract. Here power is fixed, eventually the gap decreases. Pulse, equal on and off time. Frequency is fixed, eventually the energy increases. Hyper pulse, more than 50 pulses per second. Surgeon or linear mode, as we increase, as we press the pedal, the power increases. There is a panel mode, transverse mode, ellipse mode. In newer machines there is also a torsional mode. So with longitudinal there is a transverse side to side angular action. For power settings, a roughly guide used for trenching is the grade of the nucleus into 15 plus 25. This is for quartz 4 to 6 crystals. So if lesser crystals, we have to increase the power. Now while coming back in trenching, we switch off the power, and if we are doing chopping, we off the power after the nucleus has been held. For phaco, aspiration reduced by 30%, and for aspiration of epinuclear sheet only 5 to 10% of power is usually needed. Now what is effective phaco time? So basically, to reduce the damage to surrounding tissue, especially corneal endothelial decompensation, we have to reduce the effective phaco time. So rather than only the duration, also it is important how it is delivered. So in trenching we are away from the cornea in a downward direction. There we have the liberty to increase the power for like the duration also and the setting also, but while careful, we have to be careful in chopping, especially if we are doing it in AC. Now this is about the power. So to counteract the heat which is generated, we need fluid around the tip. So it is to prevent the collapse of anterior chamber, also to prevent the built up heat, and also to aspirate the emulsate. Now what are the fluid dynamics? Infusion is equal to the aspiration, the fluid which comes in, and also the wound leak. So we have to maintain a stable anterior chamber, both should be balanced. So approximately 11 mm Hg pressure above atmospheric pressure is generated for every 15 cm rise of bottle above the eye level. So normally we keep it at 60 to 90 cm, maximum 100 cm. It generates around 70 to 75 mm Hg of pressure. So if we go beyond that, there is zonular stretch, discomfort, which leads to discomfort to the patient, especially if you are doing it topically. Then there are IOP fluctuation, which leads to chamber instability, meiosis of the pupil, and iris prolapse can occur from the wound. What is flow rate? So flow rate is the amount of fluid that comes out of eye per minute. So it depends upon the pump rotation, especially in peristaltic pumps. So it increased flow rate leads to a faster process. The phaco time is reduced, but also it leads to faster aspiration of the lens fragment, faster vacuum rise time, which can lead to sudden aspiration of tissues like PC or iris. So vacuum was how fast, flow rate was how fast, vacuum is how strong. So negative pressure with the pump generate, it propagates along the aspiration line, and with that the phaco probe holds the nuclear fragment. And vacuum rise time is rapidity with which the vacuum reaches the maximum following the occlusion. So with that depends our emulsification power. There are two types of pumps. One is a flow pump, that is peristaltic pump, which has rollers and cylinders. So when the tip occludes, the pressure, eventually the vacuum builds up, rollers they slow down, outflow decreases, and on complete occlusion the outflow is zero but the vacuum is maximum. Here the followability of the emulsate is less, so there is less PCR, less iris chafing, so it is better for beginners. On the other hand, we have Venturi pumps, which is a vacuum based pump, so it depends on a compressed gas, there is a gas cylinder which is compressed and generates the vacuum, depending that is based on the Bernoulli's principle. So here the vacuum and flow rate are proportionately linked. Vacuum rise time is fast, the process is faster, so it is better in hands of experienced surgeons. So followability is once the nuclear materials are broken down, how the fragments follow into the tip. So the green around the tip has good followability, so we have to make sure to bring the particles in that area. Around the yellow, the part near the green part, it has poor followability, so we try to bring the smaller fragments from periphery into the center, and grey is around the incision, which has no followability. Now there is one thing which leads to the complication is the surge. So when last piece is aspirated, now the occlusion suddenly goes and we don't have any other particle to come in. So here now the excess fluid comes in suddenly. So there is a mismatch between the fluid which comes in and the fluid which is aspirated out. So there is sudden deflation of the anterior chamber, and most probably in hands of inexperienced surgeons to start with, the PC comes into the probe and leads to posterior capsular rent. So to avoid that, first we have to understand the factors of phacodynamics which are responsible for surge. One is the compliance, that is the property of the tubing to collapse or deform under pressure. So higher the compliance, greater the surge. It depends upon the lumen size, more with larger size tubings, more at higher vacuum, and less with thicker walls. So thinner walls collapse fast. Hysteresis is speed with which the collapsed tube it regains its normal shape. So higher hysteresis, the tube comes back slower, so slowly the fluid is aspirated from anterior chamber, so surge is lesser. Now in higher newer machines, there is a vent, that is after the last particle gets sucked, a alternate vent is opened so that fluid comes from the alternate channels into the tubes, so that less fluid is aspirated from the anterior chamber. Also there is an aspiration bypass system, so there are small holes in the microshaft that is below the tube. So after complete occlusion, extra irrigation fluid is drawn through this tube to prevent surge. So basically lesser fluid flows from the anterior chamber into the tubings. Thank you. Second.